70% of patients are well within the first week. So after the first week. So after the first week, they're already going to the mall. The shrinking does not happen immediately.
Yeah. The pain seems to also not be long lasting as compared to surgery.
Hi guys, and welcome back to another episode of ziRight Girls. Today we're following on from our previous episode on fibroids, and today we're focusing mainly on the management on fibroids. Specifically, we're looking at uterine artery embolization, as well as the role of interventional radiology in other gynae conditions. We have a very special guest with us today. We have Dr. Dale Creamer over here. Dr. Dale, can you tell us a little bit more about yourself and the role that you play?
Talia and Lihle, thank you very much for inviting me to come and have a chat with you guys. It's nice to be on ziRight Girls. I'm Dale Creamer. I'm the head of interventional radiology at Groote Hospital. I'm also the director of Cape Town Interventional Radiology, which is a private interventional radiology firm. And I was trained at the University of Stellenbosch in radiology, and then I went to Canada and trained at the University of Calgary in interventional radiology, and I think at the moment, less than 10 true subspecialists in interventional radiology in South Africa with qualifications, as well as I have a European board certification. So there's I've made sure that this is I'm a proper subspecialist. I've made sure that I know what I'm doing, and that's why I'm really grateful to have the opportunity to come and chat to you guys about these very important topics. Yeah.
Thank you for being here and for making the time.
Yeah, thank you for joining us. Let's get right into it. So, to the general public, what is intervention radiology? Because I don't think many people know.
That's a good question. So I think the most important thing to start off with is, what is radiology?
Okay,
right?
sure.
So radiology is it's the doctors that sit in the dark rooms, right? And they look at X-rays.
Okay.
And they read X-rays, and then they read CT scans, and they read MRI scans, and any type of imaging that you can use to diagnose a problem, right? So even ultrasounds, it's anytime you need to look at a picture to diagnose a problem, that is a radiologist, right?
Okay.
And then when it comes to interventional radiology, what has happened is that we've found ways to use that same imaging to perform procedures. All right, so the procedures are minimally invasive. So what that means is that you are not doing an operation, you're doing small accesses with little needles, wires and tubes or catheters to do specific procedures. So it's like quite targeted and precise type of treatments, but using these X-rays, CT scans, ultrasound in order to perform these procedures. So that's basically what interventional radiology is. Yeah,
it's quite interesting. Maybe can you also then just tell us a little bit more about the role of intervention radiology in women's health? Because I'm sure it's more than just what we mentioned earlier about uterine artery embolization for fibroids.
Yeah. So there's I think with interventional radiology is quite an interesting subspecialty of medicine, or radiology in particular, because we get to work with a whole lot of different specialists, you know, and our focus isn't purely on women's health, but yes, we're going to talk about women's health today, and with regards to how we work and what we actually can assist with when it comes to women's health. There are multiple different ways, right?
Yes.
So the first thing, like you spoke about now, we're talking about uterine fibroids. So uterine fibroids are non-cancerous growths of the uterus, and affect approximately 60 to 70% of Black African women in South Africa. So very common condition, that is one sort of treatment method, or one type of disease that we treat. Yeah. We also manage patients who have blockages of their fallopian tubes, or their tubes, and we have performed a procedure called a fallopian tube recanalization. So at the moment, the latest research on that is that it's almost success. Its success rate is about 51%. Of patients who have this procedure will go on to fall pregnant. So it is a very, very revolutionary type of treatment. It's mainly used in proximal fallopian tube obstruction. So that is, we can help the public understand that it's just where the tubes are blocked is very important, right? So you don't always have to go to IVF. You can always, it depends where the tubes are blocked, and there's certain tests that we do that we can evaluate the extent of the disease and whether we can actually assist, right? And we also assist in something called postpartum hemorrhage. So postpartum hemorrhage is quite a serious topic. I mean, it's one of the
top 5 causes of maternal death.
Exactly. Yeah. So I think South Africa in its entirety hasn't really embraced interventional radiology like they have in my training in Canada. I mean, in the sense that I feel that most high or busy obstetric centers should have an interventional radiologist available, mainly because maternal mortality from bleeding after you deliver your baby is quite it's firstly preventable, right? And currently the only sort of saving grace for our gynecologists is that you have to do emergency hysterectomies and remove wombs, and the problems with that is that some women maybe would have wanted to have had more children in their lifetime, and now they can't. So that's quite an important thing to discuss. And we perform a procedure that is so quick, so easy, and really just makes life so simple for you guys, so you don't have to stress about because that kind of problem is a big problem when you have your patients that are bleeding and you don't know what to do now, and we are there to help. So we also manage something called pelvic congestion syndrome. So that's quite a rare diagnosis. I mean, but what ends up happening is you're having these patients who present with what we call, I mean, you look at varicose veins in your legs. When the veins don't work too well in your legs, and you see these veins on your legs, and the blood is sort of pooling in them. We can imagine that that's what happens in the pelvis as well, that the veins are not working and draining blood from the pelvis so nicely.
My sister used to call them very cross veins.
When I was...
So now they're crossing the pelvis,
I grew up in Durban, so and then I remember there were some patients that would say they were very close veins. I've also got very close veins as well. So those veins in the pelvis, which can cause us throbbing pain, and it's just not a comfortable and happy life for a lot of women. We actually found ways to redivert blood flow and to close off those veins as well, working inside the body using the x-rays and ultrasound and things like that. I've spoken to you guys about of how we actually work. So that's also another thing that we do as well. So there's a lot of the scope is quite broad. I mean, even from doing biopsies, doing special types of drainages, but so mainly in the embolization, working inside blood vessels and fixing up those blood vessels, whatever the problems may be, and using x-rays to do it. So
sounds very rewarding. And just to touch on postpartum hemorrhage, I can appreciate like where the role of interventional radiology like fits into that, because as you said, for us sometimes it's all about stopping the bleeding and saving the life. We never really go on to think about what the impact of that might be the next day, and 6 months later, and 10 years down the line, what type of psychological and social morbidity we leave the patient with, rendering her now sterile, and what type of depression that might impact on the patient who's already got another little life that they and struggling and going through that difficulty. So I can truly appreciate where interventional radiology plays a special role there. Thank you for that information, Dale.
Well, I think we're trying so hard to so at Groote Hospital, I've had meetings with our colleagues in obstetrics and gynae to try and set up the service, and I think that it's not really accessible, right? I mean, the fact is that gynecologists are having to work without the safety net, right? And I find that when I work with the surgeons, the general surgeons or any type of surgeon, whenever they have mishaps in their surgeries and they need help, that's where I come in, right? So if they've got like some bleeding after an operation and I go and I help them quickly without them having to re-operate the patient, and then that's the magic of intervention, is that we're there to actually work as a safety net to help you guys so that you're able to feel confident in your day-to-day work, that that I've always got my trusty interventional radiologist, that if I ever have a problem, I just pick up the phone and then they can sort out the problem for me, So we're trying our best to get that off the ground. And I mean, in Grootskeur, we're very, very lucky in the sense that Grootskeur Hospital is the only hospital in South Africa, whether private or state, that has 2 fellowship-trained interventional radiologists. So there's nothing in South Africa, right? It's just, we're pretty blessed there,
Yeah, like you say, imagine this is in Cape Town and in the rest of the country where access to just even a general specialist, it's quite
rare,
rare, yeah.
So guys, if you are considering a speciality, think about interventional radiology as a speciality for like all the young ones out there, the matriculants, those who are in med school at the moment are undecided about what speciality you want to do. Here's a very interesting
Louder for the people at the back.
There's an interesting field of medicine that is untapped that you can consider. So Del, we know quite a bit about myomectomies and hysterectomies as the treatment of fibroids. Can you take us through how you try an artery embolization or interventional radiology? What are the benefits, or where would that fit in over conventional therapies?
Yeah, so I think when it comes to myomectomy, so just to help patients understand, so myomectomy is when the non-cancerous growths or the fibroids themselves are removed in the surgery, right? But then you ladies will know very well that there's only certain fibroids that are accessible. Right? You can't take out all of the fibroids. You're going to take out the ones that are quite clearly visible and easily to take out without adding additional risk. So those are
compromising the uterus.
So absolutely. So that's where with the myomectomy side of things goes. Obviously, in hysterectomy, it is now removing the entire womb, and then that means that I think also something that needs to be understood is that there's also a cultural understanding about with certain. I think so in Black African women in South Africa, there's almost this feeling that remaining whole as a woman is important to them. So having a hysterectomy is not necessarily something that they would opt for immediately because they'll feel like like I'm a woman but I don't have a womb. So those are things that are quite important. But where fibroid embolization is, so uterine artery embolization, fibroid embolization, we'll use the same. We'll use these terms interchangeably, but ultimately it's the same thing, right? So with fibroid embolization, there's no limit to the amount of fibroids that you can treat, right? The bigger the fibroids, the better. It doesn't matter, right? How it works is that when we put these little tubes or catheters inside the body, so we can either go in the wrist, right? We can use your wrist, or we can use one of the groin vessels, right? I mean, one of the things that one of my patients said to me is like, "Oh, so you're telling me that I can do this procedure without taking my clothes off?" So it's as minimally invasive as that, in the sense that you can just put the small, like a drip, a long drip that I guide with X-rays to get down to the blood vessels that supply the womb, and the blood vessels that supply the womb also supply fibroids, right? And then when we get down there, we use X-rays to guide the catheter or the tube down there, and we inject these very small particles. So what these particles are like, I try to tell, and I tell all my patients the same thing, is basically that they're like little grains of sand, right? And they're specially designed to stack up against one another. So fibroids are interesting because they are growths, and when you have these growths, your body responds by creating more blood supply to them, right? So that's the whole reason why this procedure works, is because as the fibroids grow, they are more hungry for blood. They create more blood supply, So when we put our catheters or our tubes inside the blood vessels that supply the fibroids, and when we inject these particles into them, they all rush up against the fibroids and they pack up against one another, right? And when they do that, they actually block the blood supply to the fibroids. What that does is that causes the fibroids to die, right? So I think this is also something we need to chat about with regards to patients, because when fibroids die, it's not fun, right?
Okay, sure.
This isn't a magic treatment that you just wave a wand and my fibroids go away. When anything dies, there's pain.
Painful, yeah.
Right? So that you have to have, we have very, very well thought out pain protocols. So, our patients have to have management before the procedure, in the procedure, and after the procedure, and managed by people who know what they're doing in order to manage the pain. The great part, though, so the pain is severe for the first 8 hours after the procedure. So you'll probably be sleeping with, or you'll be heavy medicated during that period. But what's nice about it, though, is that after that 8-hour period, your pain takes a rapid decline, right? So you almost find that you have to suffer for a short period of time, where you'll have maybe 8 hours straight after your procedure. Most of our patients, I would say 99% of the patients, go home the next day, all right? So you will literally have your procedure, stay overnight. We actually keep them overnight mainly because we are just in
Pain
case there's a bit of
management,
nausea, vomiting, pain, just so that we can keep you comfortable. We make sure you
compassionate.
we make sure that you make sure the ladies go to the toilet. We make sure everything's fine, and then we take care of them. The next day you go home, and then you will be followed up. So you will be at home. I usually put my patients off for 2 weeks. Most patients, and maybe I'm over exaggerating, but I would say about 70% of patients are well within the first week. So after the first week. So after the first week, they're already going to the mall, right?
That's good.
I had a patient that came and saw me, and then she's actually from out of province, and she came to have her embolization done. She spent 4 days recovering, and the rest of it she took as a holiday because I had given her sick leave, right? So she was. I mean, it wasn't like she was completely normal, but there was a low grade. She had pain, but she was still able to do things and walk around and be functional, go to the mall. And then as long as she could actually go, it was kind of against my advice because I did say to her, you must make sure that you rest, So, but I think that whenever she felt that this is too much now, she could go back and rest, So you're able to move around, you're able to get up back to normal life pretty quickly. And that's the benefit of it. And that's the wonderful thing about this procedure, is that it's helping women who have these huge fibroids actually just be able to have a procedure to shrink them. And also, I think we need to talk about that. The shrinking does not happen immediately.
Yeah. So, when should they check for the shrinking?
Yeah, the shrinking is not immediate. It takes 3 to 6 months for the fibroids to shrink. All right. But what you will notice immediately is that if you've got heavy bleeding, it will immediately change. Right. Your next period will not be the same. Right. You will not have so some of the ladies end up having anemia as a complication of fibroids. Right. And what you end up finding is that immediately post procedure, their next periods and going forward, it will be markedly better. So a lot of patients actually report an improvement in their quality of life immediately after the procedure. It's the patients that have the big bulky fibroids that only really notice something's happening. After about 3 months, they're like, people are saying, hey, you're looking sexy, you're losing weight, but actually the fibroids are shrinking, so that's what happens over a period of time. And that's why, I was saying to you ladies as well, that's important that our colleagues in the gynecology world need to see the patients, collaborate with them, see that the fibroids are dying, and tell them how much they've shrunken, and make sure that the patients are well after the procedure. But so that's how it works. I hope that answers your questions.
Well, I'm already sold on uterine artery embolization. I mean, minimally invasive. The pain seems to also not be long-lasting as compared to surgery. So for people with busy lifestyles, I think it's much nicer for people to go back to their normal daily lives as quick as possible. But then, are there any long-term complications with uterine artery embolization?
Yeah, so in the wrong hands, right? So I think this is something that really needs to be quite clear, you know. So our obstetricians and gynecologists are custodians of women's health, right? And you ladies are here to make sure that that our patients are taken care of, right? So it's very important that these procedures are done with people with the right kind of training. Yeah, and the reason why I say that is that if you don't know what you're doing, you can do something called non-target embolization, right? So fancy word for, I'm making it sound super simple that there's the uterine arteries are just these like easy blood vessels to get access to, but the body is quite an interesting thing, right? Is that sometimes blood vessels are a little bit weird. Sometimes they've got connections to other blood vessels, and blood vessels that supply the womb are right next door to blood vessels that supply your bladder, that blood vessels that supply the vagina, blood vessels that supply your bum, right? There's a lot of stuff going on there, and if you don't know what you're doing, those little those little particles that we use to embolize the fibroids can go to places that you don't want them to go, right? And if they go there can be problems, right? I mean, imagine you could actually kill areas that you're not supposed to, or make the certain organs die that are not supposed to be involved, right? Yeah. So I think that's why this needs to be taken very, very seriously, right? So those are the types of complications that we need to talk about with patients, and patients should request to have these procedures done by properly trained interventional radiologists. Yeah.
Can I also ask on the back of like complications, what do the ladies need to expect? Let's say a patient has some submucous, maybe not intercavitary, but maybe just submucous fibroids. Are they going to have any like discharge, or are they going to have pelvic pain? Like, what is the recovery period in the first 3 months look like? So when we're advising patients, this is normal and this is abnormal. Like when you see this is not normal, you should let me know. And I need to bring you in. Like, what are those signs that we should be alerting patients to look out for?
So what Tali is saying is, now, with regards to some of the fibroids, there are different places that the fibroids can sit, right? So you have fibroids that sit on the outside of the uterus or the outside of the womb. There's certain fibroids that sit in the middle of the womb, and there's certain fibroids that sit just on the inside of the womb, right? So some of the ones that are on the outside, they just shrink. Some of the ones that are inside the wall of the womb, they shrink. But the ones on the inside, they disintegrate, right? So they break down, and they come out as clots and pieces, right? Those are things that are normal, right? So I often tell patients that what you'll see is you could have a discharge where you'll find like there's this weird clotty stuff coming out, but that's normal. That's the fibroid dying, and your body is expelling it, you know. So those are, but it doesn't happen with all fibroids. It happens with the ones that have communication with the inside of your womb. As they break, they come out. You know, some patients like that. You know, you get to see, my fibroid is dying. Look at it, it's coming out.
So the procedure is working. Yes, it's evidence the procedure is working.
So in preparation for referral, right? So we always like to say, like, this is a collaboration. We are partners in looking after our female patient. What can I do as a gynecologist to assist you in assisting the patient?
Yeah, so I think it's very important that we work together, right? And preferably, it'd be nice if I could have where you are based, that I'm also there to do the procedure. But unfortunately, that's not really the way our healthcare systems work, right? So often you'd have to send us a referral, and so you can contact the practice, or you can go onto our website, which is www.ctir.co.za, and maybe you can share the details for our WhatsApp line and things like that for other people who would like to refer to us. But basically, you can speak to myself or other interventional radiologists. We can discuss the case and discuss the patient, see whether what works. Sometimes it's very important for patients to have an MRI scan. So I usually we do an ultrasound in the beginning. So you'll do your ultrasound in your rooms. You'll see that they have fibroids. They've got the signs and symptoms. They fit the profile of what that they want this particular procedure and that they would benefit from it. And then you basically just write a referral to us and you say, look, this is a patient who would like fibroid embolization. She's got these amount of fibroids, and this is her problems that she's caused. Nice to have a chat with you guys and then find out what your opinions are. Then we will contact the patient and have a discussion about the procedure, and patients get the opportunity to say, look, this is something I want or something that I don't want, because it's very hard for you to tell somebody, like, I can't say I know about obstetrics and gynae. I'm not an obstetrician. I'm not a gynecologist, right? Yeah. So, but when I need someone, if I need a patient to speak to a gynae, they must speak to you. But when it comes to the procedural aspect of things, it's better for patients to speak to the interventional radiologist for them to hopefully unpack this and help them understand, what it is they're going to be doing, and then the patients have the right to make the decision at that point. So we talk to them and we say to them, look, these are your options, right? This is how it works. So, for example, we're talking a little bit about fertility.
Yeah.
So I think that's a very important thing. So a lot of women say, look, I've got these massive fibroids. I'm having many miscarriages. I want to get rid of the fibroids, but I want to maintain fertility. So we'll talk about what does the research say, right? Research says that up to 50%, 57% of women who have myomectomy can fall pregnant, right? So within also the research and the current research that's been going now is that they're saying that the range in fibroid embolization is between 32 to 57%. So it is comparable, right? It's not a set number like 57% is with the myomectomies, but that also means that there's no guarantees. If you do this, any type of procedure or surgery, there's no guarantees for fertility, right? So it doesn't mean that you are going to remain fertile. But the key is that with fibroid embolization, I spoke to you ladies about the fact that it doesn't matter how many there are, it doesn't matter how big they are, all the fibroids are going to shrink, right? Yeah. But and that's a really important thing with regards to so people may ask, why do you not fall pregnant, or why do you struggle to fall pregnant when you've got fibroids, right? And that's because it completely mangles or makes your uterus abnormal, right? It's not your normal shape of a uterus. It's very difficult for the eggs or the baby to implant and to grow, because there's all these growths in it, right? So those are the main reasons why if you shrink it and you create a normal uterus shape, you'd have greater chances of falling pregnant, right? So that's, I hope, answered your question a bit.
I think if I speak out of turn, but I think like the advantages that I am just formulating in my head as a gynecologist sitting here is the benefit of an artery embolization over myomectomy. Also, we spoke about there's no cuts in the uterus. You're not damaging the integrity of your lining or your endometrium. One of the biggest things that we do when we counsel our patients for myomectomy is that they always have to sign consent for a hysterectomy. Because if we have uncontrolled bleeding in theatre and we have to save your life. So while we're trying to do a procedure that, is going to save your uterus and allow you to fall pregnant, there's always going to be this, anxiety both in the surgeon and patient that you might lose your uterus. But I think the possibility of that might be much, much, much less in an artery embolization. And as Lihle said, like, you're selling me. You're definitely selling
me. I think it's just that there's a lot of misinformation. Yeah. Right. And also it's really nice, and I love the team approach, right? I love to work because I need to learn from you guys as well, right? There's a lot of stuff that we need to share information and learn from one another with the ultimate goal of having better patient outcomes.
I think that is the goal.
That is the
end of the day.
ultimate goal.
Yeah.
So we've spoken a lot about the advantages of UAE. So who absolutely cannot have a uterine artery embolization?
And absolute contraindications. I would say. So this is what I advise my patients, right? So let's talk about who should have a fibroid embolization, right? My opinion, and also with regards to this, not let's forget about my opinion. Let's talk about research, right? Because my opinion is the facts, right? Let's not talk about opinions. Let's talk about facts, right? So the best candidates for fibroid embolization are over 35, families. Those are the ones that are the right one. Doesn't matter how big the fibroids are. It doesn't matter where the fibroids are. There are types of fibroids called pedunculated fibroids, right? And those are the ones which can be slightly tricky. So that's why we have to do an MRI scan to make sure that if there are pedunculated fibroids, how big. So pedunculated means that the fibroid, the growth in the womb, has got a stalk. It's growing from like a tree, a branch of a tree, right? So if you block the blood supply to it, we need to know, is it going to fall off the stalk? Where is it going to go? If the stalk if it's going to fall off inside your abdomen, it can cause sepsis. Yeah, right. So so it's not like this is a magical thing that when you do the procedure, we don't want to hear from gynaes anymore. That's why the gynae is very important. You know what I mean? So we can actually fix this thing and we can make them go down. But if there is problems that happen afterwards, that's where our colleagues, the gynecologists, have to come in. We have to work together with this to make sure that our patients are well. Right. So those are the types of things. So if I had to tell you, send me the ideal patient. I've just described it for you. Over 35, completed family, doesn't matter how big the fibroids are. Perfect. Let's do it. A patient that requests or desires not to have a hysterectomy, you know, and wants to, I mean, you can have your fibroids decreased in size, and you can also improve your heavy menses or heavy bleeding during your periods. It can all happen with that procedure. So that's the ideal candidate. We have done this procedure in patients that are younger than 30. Right. The problem is that fibroids are actually driven hormonally, right? So if you have this procedure younger, the chances are it's going to grow again. I mean, as you ladies know, even if you do myomectomy, they grow back, right? I think patients also need to understand that this doesn't mean whether you have an operation, whether you have fibroid embolization, they still grow back. It's not like a once done, right? And I think sometimes I find a lot of patients saying, I've had so many myomectomies, I'm sick of these myomectomies. But the truth is that, the myomectomy has its place and the fibroid embolization has its place. In my opinion, we should, no, let's forget about opinions. In research, what you should talk about is that patients who are under 30 should have myomectomy. Right? We're trying to preserve fertility to the maximum, right? Remember, when we talked about the research, they said between 32 to 57% in patients who are wanting pregnancies, with 32 to 57% of them will be able to have have children after fibroid embolization. But this 57% is a fixed number that they've come up with, which is more than 1 in 2 patients will be able to fall pregnant with myomectomy, right? So if you're younger, it's the way to go. Myomectomy in the younger patients, I would say if you are 31, 32, 33, maybe, but the chances are that if you have it closer to 30, that you can also have a repeat fibroid embolization. So like you can have a repeat myomectomy, you can also have a repeat. So it usually happens maybe 8 years later and they've grown back, then we'll just go back. And that's why I was talking to you ladies about the fact that, the blood vessels are still intact. They just, if the fibroids want to grow again, they grow again, and we just go back again and we block those fibroids again.
Thank you, Dale, for that very informative talk about intervention radiology. So now women know that there is more than one treatment option for fibroids. It's more than just surgery. We are expanding our treatment options, and intervention radiology has actually sold me on the good quality of life, the quick recovery time, and the fact that you can actually still get pregnant with embolization. That has been very good to know, because we have been sold that if you still wish to get pregnant, rather you should have surgically removed fibroids.
We'd like to thank you for coming and making time to be with us here, and we hope to have a happy and healthy working relationship and partnership in the future.
Thank you.
And we hope
ZiRight.